Well, good morning. I'd like to thank the Pennington Biomedical Research Center, Dr. Peter Kaczmarzyk, and Dr. Daniel Shah for the invitation, in addition to the other sponsors of this conference. I'm excited to be here. Last time was pre-pandemic, so it's been a while. So what I thought we'll do, and I do want to leave a couple minutes at the end for questions or discussion, is do a brief overview from the literature. And then what can we do? And we want to look at applying system-level integration. And I'll give you examples from my hospital. And then discussion. So let us start with, let me just take you back to when this all started, which was 2020. And I think I went too fast. Let's see. Does that go backwards? He said back. Okay. So if I was a time traveler and I popped in on Earth here and I said, what year is it? And it said 2020, that would be my face, right? You all remember that. And cruising was so unattractive that if you were shipwrecked on an island, you wouldn't put up the SOS sign to be picked up. And who can forget that the most expensive currency during that time was toilet roll? And even though it's been 2 years, we still kind of feel like that, which is why you're all here today in person for the conference. So looking at that, I also want to tell you that I've just given you a health benefit. There was a study that looked at during the pandemic, if you looked at memes, you had more positive emotions and low levels of information processing. So that's a sign that we should do more meme looking at. Just keep away from the anti-vaccine ones, those ones. Okay. So when COVID started, it was scary. And there were a number of mitigation effects or mitigation things that states, the federal government did. And we recognize a lot of them, right? We shut down schools, we shut down fun places, we shut down recreation, we all stayed in our houses. And we know that some of those effects led to an increased sedentary behavior, so more screen time. We had more availability of shelf-stable and less nutritious food choices. And most importantly for our kids, there was a disruption, right, in our day and nighttime routine. So our sleep routines just went out of whack. And we're very much aware of the impact on sleep on our energy expenditure and our energy balance. We had decreased opportunities for physical activity, particularly for people who lived in neighborhoods that weren't safe. And the social isolation increased the chances of feeling depressed, sad, anxious. We see that in the schools, and somebody talked a little bit about that today. And then the increased family struggles, and I think that's huge when we talk about kids, right? Because the family, the parent, they are exposed to food insecurity, to financial instability. And if you do remember too, if you went back to 2020, there was a huge racial reckoning for the country with the George Floyd event. So it wasn't just that we're dealing with a pandemic, we had multiple socio-cultural things happen, and they all kind of came together. So it is not surprising that the effects that we see have happened. We see slightly higher rates. We definitely have seen post-pandemic higher rates of obesity. So our children with obesity have gone up. And it seems to affect kids that already have severe obesity. So, and that's the line here where we are. Finally got that to work here. Severe obesity, you can see post-pandemic, we saw a really big jump. And this is coming from EMR data that the CDC put out, as well as we saw also the largest rise in our 6 to 11-year-olds. And there are multiple reasons people have put forward as hypothesis for why it affected that age group. So in our hospital, we decided to step back and kind of look at the early effects of the pandemic. As a clinician, and for clinicians in the room, whether you're a dietitian or a physician, the amount of weight gain that kids came into the office with was just mind-boggling, right? You would look at it and like, what? 25 pounds in this short period of time? So we decided to look at the early part of the COVID pandemic when we put in our mitigation efforts. Because at that time, you had the highest impact of all the closures. And what we did was we went into our electronic health records, and we have a huge primary care network. We are predominantly Medicaid, so about 90% of our kids are Medicaid. We are also predominantly more non-Hispanic Black that we see, so about 55, 60%. And rather than doing what the earlier study did, we picked a cohort of kids that were seen 2 times in 2020. So they were seen pre-pandemic in the first quarter of 2020, ending in March, which was when the state of Ohio closed down everything, like 3rd week of March. And then we looked at the 3rd quarter of 2020, which ended in September. So we're looking at the effect over a 3 to 6 month period. And we did do some regression analysis controlling for that time period. You know, if a patient came in and it was 4 months or 6 or 3 months, and the results were very similar. We tried to take away the kids who had chronic health conditions who could change the results, and then kind of took out data that was implausible. So what we found was very similar to the earlier study I showed, which is we found that the proportion of kids, if you added a BMI at the 85th percentile and greater, went up from 37.8% to 44.6% in our cohort. And there have been multiple studies looking at the prevalence of obesity, and the range really is anywhere from 2 to 7% in the first year, and there's some studies that have gone into 2021, and they're seeing again that same 2 to 6% range. So over this 3 to 6 month period, about a quarter of them gained more than 5 kilos. And 5 kilos, folks, is 11 pounds. And then we have a little less than 5% gained more than 10 kilos, which is 22 pounds. We found that the kids who had severe obesity gained the most weight. So they gained about a median, not mean, a median of 5.8 kilos. So we're talking about 13 pounds in that subgroup. And for those with obesity, it was 4.3 kilos, about 10 pounds. And overweight, 3.2 kilos, and if they were normal weight, 1.7 kilos. I think if in a 3 to 6 month period you change your BMI by 2 units as a child, right, thinking about the growth chart, the likelihood is that you're going to move from one category into the other, because that's a huge, sharp increase over a short period of time. So we went back and we kind of looked at that. And interestingly, for the kids who came in underweight at the beginning of the pandemic, we actually found that a large proportion of them at the end of the pandemic were now could be categorized as having normal weight. So we are exploring that a lot more. But here are the kids that came in healthy weight. And you can see about 14% became overweight. Obesity was 2.3%. Some moved backwards, and about 81, 4 out of 5 remained normal weight. And same thing with this graph. These are the kids that came in. They had overweight coming in. And you can see the difference. You can see that the shifts to a more concerning weight increased the more the child's weight category was overweight, obesity, or severe obesity. So the graph I didn't show was the severe obesity. I mean, most of them remained with severe obesity. So if you look at COVID and treatment, and there are some studies, my good friend Dr. Cook will talk a little bit more about treatment later on. One of the things that's coming across to us is that for the kids that were in treatment, whether it was a study or in clinic, that their outcomes were not as good during the pandemic months, particularly early in the pandemic. And this is a study, I think, from Worcester, Boston, that found that. So I'm going to shift base a little bit. We've talked about this to look at disparities. One of the things that is sad, I think, when we think about obesity or we think about a lot of the health impacts, right? Big nutrition-related diseases or just general diseases, is that it disproportionately affects people who are most vulnerable, right? And you can see that this is just looking at SARS infection by race and ethnicity. And yes, the categories of race and ethnicity is not biological. We are quite aware of that they are social drivers defining the experience people have. But a lot of these studies were using these categories. So you can see of 1,000 children, that's the number that was positive, but who was most likely to be positive? Hispanic, non-Hispanic Blacks. And you can see that when you looked at the median family income in quartiles, the people in the lowest income group also were more likely to be infected. This is a similar study. This, I believe, came out of CHOP. It's an Ihuoma study. And the reason I put that in is that it's looking at, this particular graph is looking at public and private insurers. And you can use public insurance in some ways, right, as a proxy for income. And you can see that the blue line really are publicly insured kids. They're already coming in with higher rates. And post-pandemic, which is the dotted line, kind of even went up much, much faster than those in private. I want you to keep that in mind when I show you some of our Columbus data. Okay. So when we talk about disparity, let's look at our Columbus data. In Columbus, we get data from our primary care network. It's huge. There are like 13 clinics. They see more than, 200,000 kids. And so we track them, and that's what I would call the urban practice network. We're predominantly Medicaid. We see more younger kids. But as part of an initiative I'll talk a bit about, we also partner with a large private practice network in town. And they have predominantly more private insured kids. They see slightly older kids, and then definitely much more non-Hispanic whites. So what we did is every year we get data, and we have a data use agreement with this private practice network where we can pull in their data. And I'm starting by showing you the yearly data from 2019, 2020, and 2021. When we combine the data, the increase from 2020 to 2021, I think I went back. Let's see if we go back. The increase is 4.2. So the first year we went 2.7 when it's combined to 4.2. But I want you to see the Nationwide Children's Hospital data, just how huge that increase that happened for those kids when you looked at overweight and obesity. And this is the data that came in from the private practice alone. So what is happening? We're very much aware, and we talked a little bit about this, that this is an intersection of so many factors. And our looking through one lens is never going to be enough. Obesity in itself is a risk factor for so many things. It's a linchpin disease, that's what I call it. And it's pretty crafty. It's very difficult to kind of get your hands on it because it's just not about diet and activity, right? It's about our biology, it's about our physiology, it's about our genes, it's about our social drivers. I mean, you can list anything and there will be a relationship to obesity. And with COVID kind of broke that open for us. It said to us, slow down, let's move away from willpower and our ability to resist the chocolate donut. And let's go back and really look at what are you doing? How have you set people up to be healthy? And we've talked a lot about that, just even having school meals for every single kid, because the school meals, like Mr. Abraham said today, is like one of their healthiest meals they can have in a day. And there are all these chronic diseases, everybody with it had a higher risk. And sitting right on top of it are those social determinants of health. So how have we tried to address this at Nationwide Children's? I put in this slide because I didn't want to miss all the other major things going on with COVID, obesity, right? More hospitalizations, more severe disease, definitely more diabetes. We're seeing it both for type 1. We're making the assumption that type 2 also went up based on these numbers in this study. So these are kids who had COVID infection and then looking at their turnover into diabetes 1 month post-infection. And then mental health. So I think there are a lot of adjacent diseases also. So there are comorbidities of obesity, but there are adjacent problems to obesity, like your mental health, et cetera. And all those things make treatment difficult. Just make sure. So this has to do with kind of just what our daily lifestyle was for some of us, going back to our means. So what can we do? Peter and I are part of the roundtable on obesity solutions in DC, and a lot of our work in the last 3 years has focused on system science, right? And I think at the grassroots, system is really about looking at sectors and how do we integrate. So a lot of the examples that have been given have been about sector integration. And so we've taken that back, and this iceberg is very familiar to most of you. That it's not what we're seeing, right, that's going to torpedo us. It's what's underneath. It's our mental model, our ability to separate a patient's weight from the patient. So Kayla has obesity. Kayla is not obese. There's a separation because I see Kayla in her beauty, right, and how wholesome she is, and her weight doesn't define her. So they're mental models, social norms. Even when we talk about personal responsibility, those are all mental models of how we see this disease. And then your system structure, what are the things we have? So the USDA, the Hunger Conference, the White House Conference, really looking at systems. Because, I mean, you're not going to ask me to exercise if my neighborhood is unsafe. That's just a waste of time. And then there are patterns of behavior which allow us to go down to the individual level. So Winston Churchill said, never let a good crisis go to waste. And I would say never let a crisis go to waste, because honestly, COVID was not a good crisis. And what it has done, I think even in the conversations we have now, across board, is very different. You get a sense there's a political will to do things that we wouldn't have done 3 years ago. Right? So that's taking our COVID crisis and making it not go to waste. So there are a couple things, and it starts with really, when we talk about system, looking at those historical, social, economic, fiscal, and policy contexts that are so important to health. We've traditionally kind of looked away from them, but they've come back up, right? And we can see that when we compare ourselves to other industrialized countries that may have, and not that I'm proposing it, but may have universal health care. I mean, there's something huge about getting that $2,000 bill because your son had an ACL surgery, and you're saying to yourself, well, how is the lady who earns much less than me going to afford this? So we're able to look at what are the things, looking at institutional, structural racism that makes things inequitable, that affects our health and affects our children when we look at obesity. And that links into those systems. So in the red box, I have a number of systems that need to change. I think that was one of the things that was exciting about the conference, right? We have ambitious goals. And when you're being ambitious, you're not on the top. You're not looking at the event. You're right down at your bottom leverage points, right? You're hitting the systems. And then we can talk about these behaviors that we have. You know, the things we do and the foods we eat and the choices we make and whether we get up and exercise and whatever it is else that our kids are doing. So I think it's thinking about it stepwise, but in a way that integrates it. So at Nationwide Children's Hospital, our hospital, the board decided that they really wanted to do a comprehensive population health initiative. They modeled it after vital signs. So vital signs is not a concept that was developed at Nationwide Children's Hospital. It was actually put forth by the National Academy of Medicine in 2015. And it felt that hospital systems are anchor institutions, and they should be responsible not just for the people that walk through their doors, but for the community that's around them. So a lot of it focused on the adult health system, and Nationwide is trying to look at it from a pediatric lens. So this is what they've come up with. They identified 8 health indicators, of which obesity is one of them. And the most important thing is to look at it from a population lens. Now, the question is, how do you affect a whole county or a whole parish, as you say here in Louisiana? I don't really know. All I know is that we've been asked to be ambitious. So we are being ambitious and we're being aggressive. And we are learning along the way. So these are the 8 indicators. It's amazing when you look at things like infant mortality to just understand the inequity that's sitting in there, right? That education as a Black woman doesn't wipe away that I have an increased risk of infant mortality, and doesn't wipe away the fact that I have an increased risk of having a preterm baby. So obesity is one. We're looking at measurements that need to be aspirational with tests of change. It's population level, there's community accountability and partnerships. You cannot do it alone. And it addresses disparities and social drivers of health. So I will provide an example. You have great people from USDA and the nutrition system that have given multiple examples. I will provide an example more from the healthcare system. So this is a busy slide, but it kind of gives you a sense of where Ohio is. And the hospital sits in Franklin County. So since it's population level, we're using Franklin County population numbers. So in Franklin County, as of the last time we got data, which was 2019, we had about 31% had overweight and obesity. Now, if you're going to do interventions and you're going to measure them, you need data that you can get to quickly and multiple times. The data that the state and the county get can't do that. So one of the things we tried to do was to look for a data source that will allow us to test some of what we're doing, but aligns with where Franklin County numbers are. And interestingly, I showed you the combined data of our network and the private network. So the rates are very similar. They're actually more similar when you combine them than when you look at NCH. Because we have more of a footprint in the hospital, what we decided to do was to select data that was current, so I can get to it, boom, boom, boom. It's set up, it's a report, and it's complete. So our data source comes from the primary care network, and I talked a little bit about that. And what I want you to see is where we started. So we were about here when we started the pediatric vital signs. Now, did we make it drop from 38.7% in terms of, let me step back. So what you're looking at is every quarter we get data of everybody who has been seen in that network that has a weight and height. And we get a percent of the proportion of kids seen during that time that had a weight and height, a BMI percentile above the 85th percentile. So every quarter the data comes in. And this is using more of a quality improvement measure metrics. So here, and we have a lot of data back to 2015. We could go back retrospective. So I show you about 2 years retrospective data. And this is really where we started talking about pediatric vital signs. And you can see there was a downward trend. I don't think it's really because of all we did. It could just be that we talked more about it, right? So our physicians were more aware and did more. We did a couple things. And then the pandemic hit. At the end of Q1, you can see what the rates were in the kids that came into our clinic. It was just a steep climb each quarter. And then it seemed to top out at Q1 of 2021 and then slowly started coming down. So do I support the mitigation efforts that were put in place? Absolutely. Having vaccinations allows us to move around. But obviously there's something happening. And what is happening is the differential impact of COVID on the kids, right? And the kids that came into our system for healthcare. So I'm going to, this is 2021, last quarter of 2021. This is the chart we typically use when we look at what we're doing, and it has the last 2 quarters of 2022. So that fall has stabilized a little bit, and we're seeing more at about 41, 42%. Think about that if you're in a clinic. The pediatrician it has 42% of the kids that walk through their door that they see have overweight or obesity. And it's stabilized about that. What is interesting is this is where we were pre-pandemic. So how are we doing our obesity PVS? We're talking about integration. We're looking at 3 different areas: health, eating, active living, education, and outreach. Education and outreach, we do a lot with our physicians. So we do the Pediatric Echo Network, which I know you guys do down here too, to train. We provide our resources. And then we select specific areas that we'll work on. And this year we decided the hospital will be a convener for a large coalition that already exists in Ohio that was kind of being sunset. So we stepped in to take that up because this is a population health initiative, and as a hospital, we can't do it alone. This is our approach. We select community things, system level things we're gonna work on. We look at the individual level because, believe it or not, studies suggest that what you do in the individual level has actually the bigger effect size than what you do if it's just a community program. And our hope is that we are able to do some integration. So let me end by giving you an example of what that looks like for us. So there's a nonprofit, it's a food nonprofit that's called Local Matters. You should check them out. I just adore them. And they're really big into social justice around food. They partner with farms. They're big into food access. They've done food dropouts. They have a big community garden. They do community gardens in preschool, elementary schools, and they're really interested in working with poorly resourced neighborhoods. So one of the things they have is called a veggie van, which moves around, and it comes to our clinics. So it sits outside and people can go there and buy stuff. And I'll talk a little bit, if people have questions, I'll leave some time how financially this is being supported. We can talk about that. The other part is nutrition education is their other pillar, and we partner with them also on nutrition education. So we've had cooking classes, we do webinars, and we are their evaluation arm of whatever Local Matters does with us. So we evaluate that data, looking at pre-post knowledge behavior change. We were really big on food advocacy at the state, local level, and over COVID, we kind of partnered with them. Most of you are familiar with the farmers to families' food box program. So the center became a site, and we kind of partner with them as how we put that out. So this is one of our nurse practitioners sitting on top of the boxes. I don't know if anybody did this, but when they come, they don't give you 10 boxes. They give you a whole pallet of boxes. So this is the front of our clinic. And through many partnerships, we would distribute the boxes. I mean, there have been positives and negatives about this program. But what we found was that a lot of the people who were lining up were our own employees would line up for these boxes. And initially, we would say, no, when the patient is done, then you can come and have what's left over. And then we recognized, no, we didn't want to do that. Okay. So I think I'm going to end. I don't have, I'm not sure I have enough time to go through, but I was at the conference on to end hunger, advance nutrition, and improve health, and it was inspiring. The room was full. President Biden definitely spoke with a conviction to do big things. I think one of the things that struck me was that they already had an $8 billion commitment from other organizations towards this work. And I mean, it's impossible to do anything without a private-public partnership. So I won't go through the pillars. We talked a little bit about them. For me, what do I really want? I want free food in school for every single child. I mean, I think it's just unconscionable. And I've been part of a task force, and they looked at how much that would cost, and it's something like 10 billion, which is like nothing over 10 years or something. I mean, the amount of money compared to what we spend on other things is just negligible. So I think it's the political will, and our hope is that as we move forward, we're able to address some of these social drivers of health that COVID broke open for us, right? It wasn't like you couldn't hide any longer. And collectively as a system, we're able to make a big difference. So yes, COVID is still around, whether we mask or not, or meet or not. And sometimes it feels like this, like we're going in loops. But I think the key is don't let a crisis go to waste. That's what we're doing. That's what was happening at the White House conference yesterday. And I'm optimistic about what the future brings. Thank you.